Welcome, my trailblazers. Sometimes a paper comes out that's so practical and so relevant to what we do in digital pathology and medical AI that I just know we have to talk about it. And actually, I would probably have one of these papers every day. But here I'm talking about this paper, a guide for the deployment, validation, and accreditation of clinical digital pathology tools.
Learn about the newest digital pathology trends in science and industry. Meet the most interesting people in the niche and gain insights relevant to your own projects. Here is where pathology meets computer science. You are listening to the Digital Pathology Podcast with your host, Dr. Alexandra Zhurov.
This one is co-first authored by Andrew Janowick and Johan Ferrari. And with Andrew, we already did several podcasts together. We did a webinar series on HistoQC. He's very active in the computational pathology space. And now he co-first authored this paper and reached out to me asking, hey, can we do something about it? So I'm like, yes, let's do a podcast. And we did it. It's not this podcast. The one with Andrea as my guest is going to drop probably within a month. And in that one, we didn't go into every detail because it's a 28-page paper. So we focus on the key ideas and, the behind the scenes. But because this paper is such a valuable guide, I decided to bring in my AI co-hosts again to unpack it for you. So let's dive into it.
Thank you, Dr. Alex, for the intro. Welcome to the deep dive. Now, if you're one of the people really pushing the boundaries, integrating computational tools and AI into clinical practice, you probably know this already, the tech challenge, building the model. That can sometimes feel, almost small compared to this sheer logistics and frankly, bureaucracy of getting it deployed.
Right. We're talking about that big leap, aren't we? Moving beyond just glass slides to these high-res whole slide images, and crucially, using validated computational analysis.
Exactly. This is absolutely the new frontier. And for you trailblazers out there, the ones actually making this happen, we're doing a real deep dive today into the rule book for clinical implementation.
And we've got a fantastic resource to guide us. It's a practical, honest-to-goodness, real-world framework that comes straight from Geneva University Hospital's HUG, as they're known.
HUG. They handle a massive volume, don't they?
Huge. Over 230,000 slides every year. And they've basically documented their entire pathway. The development, the validation steps, the accreditation needed to get these clinical digital pathology tools running, especially when they're set up as laboratory-developed tests, or LDTs.
And that level of detail is precisely what's often missing, isn't it? You see a lot of high-level recommendations, kind of theoretical.
Very high level.
So our mission today is really to pull out those specific, practical, audit-ready steps. The things you need to ensure reliability, accuracy, and the absolute bottom line, patient safety and compliance when these really sophisticated tools become part of the routine diagnostic workflow.
Let's get into it.
Okay, first things first. Before we jump into their 4-phase workflow, we really need to unpack some of the jargon, the regulatory language. We hear these 3 terms constantly: qualification, validation, and accreditation. Can you break those down for us, especially in the context of, say, an AI tool for diagnostics?
Yeah, absolutely. And getting the distinctions right is, critical. So qualification, think of that as being all about the specific equipment and the system itself.
The hardware and software.
Exactly. It's verifying that your scanner, your server, your viewing station, all that stuff is installed correctly and it's actually working the way the manufacturer says it should. That's your basic check.
Okay, so qualification is like the mechanical checkup. Does the scanner scan properly? Does the software load?
Yeah.
And they break that down further, right? Design, installation, operational, performance qualification, DQ, IQ, OQ, PQ.
Precisely. Those are the steps to confirm the equipment itself is sound. Now, validation. That's the next level up. Validation is about ensuring the entire process, the whole workflow, consistently does what you intend it to do.
The whole process.
Meaning, if you're validating a DP tool, you're confirming that your qualified system, combined with how the AI performs in your lab, produces reliable, accurate, and consistent diagnostic results. It's about the end-to-end performance in your specific clinical setting.
Got it. So qualification is the gear. Validation is making sure the gear plus the method gives the right answer consistently. So where does accreditation fit in? Is that the official stamp of approval from outside?
That's a good way to put it. Yes, accreditation is that external certification. It comes from bodies like SOCOLP or SAS in Switzerland, and they look at the lab's overall practices.
It's just the tool.
No, the whole lab. It's quality management systems, the competence of the personnel, how everything operates against established standards like ISO 1500 ID9.2022. And here's a really interesting point they make. Usually, the DP tool itself gets validated as an LDT within that already accredited workflow.
Okay. So the accrediting body isn't approving the specific software product itself necessarily.
Not directly, no. They're certifying the laboratory's implementation, the controlled use, the environment around the tool. It's about how the lab manages and uses it safely and effectively.
That's a super important distinction for labs wanting to bring in their own tools or customize things. And the source material really hammers this home. Okay, LDTs and, say, FDA cleared or CE-IVDR marked devices have different regulatory paths initially,
And it's a big, but all diagnostic tests, doesn't matter how they're classified, have to go through local verification or, more likely, full validation before you can use them for patient care.
non-negotiable then.
Absolutely non-negotiable, because that local validation proves the tool works reliably with your patient population, your slide preparation, your staining protocols, all that local variability.
Makes sense. Okay, so doing this right clearly needs a team effort. The framework outlines this multidisciplinary group who needs to be involved, and they mentioned one role being kind of make or break for long-term success.
They did. It's quite a team. You've got your technical folks, the algorithm researcher, the AR, who comes up with the initial model. Then there's the deployment engineer, the DE, we'll come back to them, and IT staff, of course.
Yeah, and on the medical side.
You need an experimental pathologist, the EP, who helps define the clinical need and sort of beta tests it. And then the routine pathologist, the RP, they're the end user, focused on usability, ergonomics, how it fits the workflow.
Like oversight, I assume.
Oh, yes. The laboratory manager, the quality officer, who's crucial for liaising with accreditation bodies and overall departmental leadership. But the one they really highlight, it's the deployment engineer, the DE.
Right. Why is the DE so critical? What's this hardening they talk about?
So the DE is the technical linchpin. They take the algorithm, which might be brilliant but is still fundamentally research code, and they harden it. They turn it into a robust, reliable tool that can actually run day in, day out in a clinical production environment.
And hardening involves?
It involves everything needed to make it work reliably and safely in the real world. Integrating it with the hospital's, frankly, often messy systems, the EHR, the LIS, the image management system, the IMS, setting up bulletproof error handling, logging everything for traceability, ensuring security, meeting compliance standards. Yeah. Without a good DE, that amazing research algorithm, it just stays a research project. The DE is the one who translates the potential into a maintainable, usable clinical reality that can last for years. They own its technical life.
Okay, so you've assembled this complex team tech, medical, quality.
Yeah.
How do they actually structure the work? How do they go from idea to validated tool?
They break it down into 4 main phases, and these aren't always strictly linear. There can be some iteration. It's pre-development, development validation, and finally, production.
Let's start with phase 1. Pre-development. You said earlier this is maybe the most critical.
Arguably, yes. For efficiency, definitely. This is where you really nail down the why and the what. Define the clinical need, the objectives, the constraints. What absolutely must this tool achieve?
And the output here is key documentation, right?
Exactly. It's what they call the project plan package, or PPP. This bundles together the overall project plan, the detailed software specification, a thorough risk assessment, thinking about what could go wrong, and, crucially, the validation plan, the VP.
And why is that validation plan so vital before you even start coding?
Because it defines your success criteria. If you know up front, in black and white, exactly what performance level the tool needs to hit to be considered acceptable for clinical use, what sensitivity, specificity, maybe time savings you design and build towards that target from day one.
Avoids that awful scenario where you finish development, run validation, and realize, oops, it doesn't meet the minimum bar.
Precisely. That means costly rework, delays. Getting those acceptance criteria in the VP lockdown early saves enormous headaches.
What kind of data should labs be gathering right at this planning stage? Especially if, say, the goal is improving efficiency.
They stress the need for unbiased baseline measurements. So actually time pathologists doing the task without the tool versus potentially with a prototype or mock-up get real numbers to justify the whole effort.
Makes sense.
And another really practical tip from Hug, Keep the whole slide images you use for those baseline timings. Archive them properly.
Why is that?
Because validation might take months.
Hmm.
If you can reuse those exact same slides later for the formal validation comparison, it strengthens your statistics. Plus, it accounts for things like pathology reading washout periods, making sure pathologists don't just remember the cases.
That's smart, a very practical detail. Let's look at their example, the H. pylori tool. What did phase 1 look like for that project?
For H. pylori, that's their tool for detecting H. pylori bacteria on IHC Spain slides. They spent about 15 to 20 hours just on this pre-development planning.
Okay.
They defined the main goal very clearly. It needed to be a super sensitive screening tool, aiming for nearly 100% sensitivity. The big value add wasn't necessarily finding cases humans would miss, but achieving a significant, measurable gain in time to diagnosis.
And integration.
That was also a requirement right from the start. The results had to show up seamlessly right within their existing image management system. No separate windows or logins.
Got it. Okay, so planning done. Phase 2 is development. This is where the coders get involved, the algorithm researcher, the deployment engineer. What are the key things to watch out for here, technologically speaking?
Well, the choice of technology stack is pretty fundamental. You might do initial research in, say, MATLAB, but Hug strongly recommends picking something suitable for production early on.
Like Python.
Python with libraries like PyTorch or TensorFlow is often preferred, yeah. It tends to integrate better into clinical systems down the line. But the really big warning is don't change your tech stack between development and deployment.
Why not?
Because if you develop and test in one environment, say MATLAB, and then rewrite it in Python for deployment, all your performance results, your initial testing, it could be invalid. The rewrite might introduce subtle differences. You basically risk having to redo the hardening and maybe even parts of the validation.
Ouch. Yeah, that sounds like a nightmare you want to avoid. So for H. pylori, they used Python and PyTorch. What were the big challenges they hit during this development phase? Was it the AI model itself?
Interestingly, not primarily the model, though they did make specific choices, like labeling ambiguous regions as positive to boost sensitivity. The biggest time sink, according to the paper. Integration.
Getting it to talk to the hospital system.
Exactly. They had to implement proper DICOM support, not just viewing, but downloading slides, sending annotations back and forth, using the IMS's API, transmitting the image results, using DICOM C-Store, all that plumbing work.
So a key takeaway there is that the integration piece, fitting the tool into the existing hospital tech environment, can often take way longer and be more complex than developing the core AI algorithm itself.
It often dictates the real timeline, yes, especially with older or less flexible LIS or IMS systems.
Okay, so the model is developed, the integration groundwork is laid. Now we move into phase 3, validation. But it starts with something called the algorithm hardening stage. You mentioned the DE owns this. What happens here, and why is it like the last chance saloon before locking things down?
It really is the last chance for significant tweaks before formal validation begins, which effectively freezes the tool's version. Hardening is all about taking that functional but perhaps fragile development code and making it truly production ready.
Robust, secure.
Exactly. Robustness, security, seamless integration hooks for the URLisms, detailed logging so you can trace exactly what happened if there's an issue, and building in automated fail-safes. What happens if the network drops mid-analysis? What if the slide data is corrupted? The hardened tool needs to handle all that gracefully.
And the H. pylori example shows this isn't always a one-shot deal, right? They had to iterate during hardening.
They absolutely did. They first deployed a beta version, clearly marked research use only, and containerized it for easier management. But the initial feedback, particularly the pathologist confidence surveys, came back a bit low below their target score of 2.7 out of 3.
Uh-oh. So what did they do?
They realized image quality artifacts, things like tissue folds, bubbles, out-of-focus areas, were tripping up the AI and confusing the pathologists. So they integrated an open-source tool called HistoQC.
For quality control before the AI runs.
Precisely. HistoQC automatically checks the slide image quality and can filter out or flag these problematic areas before they hit the H. pylori model. This improved the input quality.
Smart. Did they do anything else?
Yes, and this was crucial. They built a feedback mechanism directly into the IMS. While reviewing, pathologists could quickly flag image patches the AI analyzed as either correct or incorrect.
Closing the loop.
Exactly. That feedback wasn't just noted, it was used to retrain the model. This cycle of deploying, getting user feedback, using QC tools, and retraining was key to getting the tool across the line for user acceptance and performance.
Okay, so hardening complete, version locked. Now it's time to formally execute the validation plan. This is where you prove it works according to those predefined criteria. What was the final verdict on H. pylori? What was the payoff?
The results were pretty compelling, actually. First, the main goal, time saving. They showed a statistically significant 26% reduction in the time needed for diagnosis, right within their standard IMS viewer. Average time dropped from about 36 seconds to under 27 seconds per case.
Wow, 26% is significant.
It really is in a high-volume lab. Second, accuracy. They hit their target of being a highly sensitive screen, achieving a 0% false negative rate at the slide level. It didn't miss any positive slides.
Perfect for a screening tool.
Exactly. And third, usability. That pathologist confidence survey score, which was low initially, after the improvements, it jumped to an average of 2.93 out of 3, comfortably exceeding their 2.7 target. They also checked throughput. Average analysis time was under 2 minutes, well below their 5-minute requirement.
So it hit all the marks.
Yeah.
Faster, accurate enough for screening, and the pathologists were happy using it.
Right.
That sounds like a successful validation. What happens next to make it fully operational?
2 key things: official sign-off for production use and drafting the essential standard operating procedure, the SOP.
The SOP. Often dreaded, but necessary.
Absolutely necessary. And HUG emphasizes it needs to be a living document, constantly updated, and crucially tailored for 2 different groups.
Who are they?
You need instructions for the routine pathologists, how to access the tool, how to interpret the results, what are its known limitations or tricky edge cases, and then you need a section for the lab techs or the DE, how to install updates, perform maintenance, troubleshoot common errors, and importantly, how to manage the logs for traceability.
Makes sense. Different users, different needs.
And flowing from the SOP comes mandatory training. Every RP and relevant tech needs documented competence training before they touch the tool for clinical work. They have to understand what it does, how it works, and critically, what it doesn't do.
Okay, tool validated, SOP written, team trained. It's live in production. Is the job done?
Not even close. Now you enter the long game.
Yeah.
Phase 4, production, which is really about perpetual monitoring. Once it's validated, you have to continuously ensure it stays validated.
But you said the algorithm is deterministic. It shouldn't change on its own, right? So if performance drops, what's usually going on?
That's the key insight. If you see a validated, deterministic algorithm start to perform worse over time, your first suspect shouldn't be the algorithm itself drifting. It's almost always a sign that something external has changed.
Like the staining.
Exactly. Maybe a new batch of reagents is slightly different. Maybe tissue processing or section thickness has subtly shifted. Maybe even scanner calibration is off. The drop in AI performance is actually a symptom telling you that your upstream lab processes need attention to bring them back into control.
That's a really important way to think about it. The AI becomes a kind of canary in the coal mine for your pre-analytical variables.
In a way, yes, it demands consistency in everything that comes before it.
So how do labs actually do this ongoing monitoring?
It involves a couple of layers. There's internal quality control, IQC, where you periodically rerun the tool on a known set of slides, maybe some challenging cases, to check consistency. And then there's external quality assessment, EQA.
Comparing with other labs.
Right, participating in proficiency testing schemes, like the QS or others, where available for that specific task.
Yeah.
Seeing how your results stack up against peers. And HUG also recommends automated surveillance.
Like what?
Like continuously tracking the distribution of the AI's prediction scores using statistical process control methods, think Westgard rules or Nelson rules, or monitoring the outputs of those QC tools like HistoQC. If these metrics start to subtly shift over time, it can give you an early warning of potential issues before they impact diagnostic accuracy.
Okay, so this whole framework, pre-development, development, hardening, validation, monitoring, provides a really robust path for getting a tool working safely and effectively within one institution. But the paper points out a massive challenge for the field as a whole: generalizability. Why is it so hard to take a tool validated at HUG and just plug it in somewhere else?
The million-dollar question. It really boils down to variability at multiple levels. First, the obvious ones. Staining protocols are different everywhere. Scanners are different models with different settings. Those alone require site-specific adaptation or validation.
But it's deeper than that.
Much deeper. The major hurdle is the fundamental difference in hospital IT infrastructure. Every hospital's LIS and IMS systems are different beasts, often homegrown or heavily customized. Their network setups vary, the available computing power is different, even how they code clinical data can be completely non-standardized.
So the integration work, which we already said was a huge time sink.
Has to be largely redone or significantly modified for almost every new site. There's very little plug and play right now. And crucially, remember that LDT validation status, it's tied to the specific lab. You cannot just transfer LDT validation from one lab to another. Each lab has to do its own.
Wow. So every single institution that wants to be a trailblazer here essentially has to go through this entire rigorous cycle for their specific environment for each tool.
Pretty much, yes. That's the reality today. Successful deployment isn't just about having a great algorithm. It needs that technical integration skill, strong governance, committed resources, and building that user trust through transparency and continuous feedback, especially as these tools start tackling more complex jobs, like predicting prognosis or treatment response. The rigor has to scale with the complexity of the task.
Okay, so we've really mapped out an incredibly rigorous journey here, haven't we? From just a research idea all the way to a fully operational, monitored clinical tool. It's iterative, it's scientific, and it has patient safety embedded at absolutely every stage.
It has to.
And it's crystal clear that the integration phase, dealing with often legacy IT systems like the IMS, that's frequently the longest pole in the tent, resource-wise.
It's often the bottleneck, yes.
Mm-hmm.
The cost of trying to standardize within a fundamentally non-standardized healthcare IT landscape.
Right, so let me leave you, our trailblazing listeners, with a provocative thought to maybe mull over within your own institutions. Given this reality, the sheer complexity of hospital IT, the fact that integration often takes longer than AI development, and the huge maintenance burden when every tool is plumbed in slightly differently, how can your organization maybe prioritize developing some kind of centralized, site-specific software development kit, an SDK?
An internal toolkit.
Yeah, something to standardize those common functions, talking to your specific LIS, your specific IMS,
Right.
handling your security protocols. Could creating that kind of shared internal toolkit help streamline future DP tool deployments and maybe prevent some of this massive duplicated integration effort for every new project?
That's definitely something to think about. Creating that common technical language internally could potentially accelerate things significantly down the road. Interesting thought.
Back to you, Dr. Alex.
Thank you so much for staying till the end. It means you are a real trailblazer. If you are just starting your journey in digital pathology, I'd love to give you my book as a gift. The book's title is Digital Pathology One-on-One, All You Need to Know to Start and Continue Your Digital Pathology Journey. Very helpful resource for those entering the field, and the PDF version is free. So the link to download it is in the show notes. Go grab it, and I talk to you in the next episode.